It's like a constant war, and you wanna settle that score, but you're bruised and beaten, and you feel defeated. This goes out to the heaviest heart. Oh, to everyone who's hit their limit, it's not over yet, it's not over yet. And even when you think you're finished, it's not over yet, it's not over yet. Keep on fighting, out in the dark, into the light. It's not over, hope is rising. Never give in, never give up, it's not over yet.
So welcome to the last session of the YES webinars for this year. Today we have two very important speakers to close the year. So let me introduce Dr. Ruta Yardi. She's an assistant professor at the University of Kentucky in Lexington. She's the North American representative for ILE, yes, and involved with several committees from the American Epilepsy Society. She completed her residency and epilepsy fellowship from the Cleveland Clinic, during which time she had published peer-reviewed articles on outcomes of epilepsy surgery in STEAM journals like Lancet Neurology and Epilepsy. And also let me introduce Dr. Lara Jehi. She is a professor of neurology at the Cleveland Clinic Lerner College of Medicine, the Chief Research Information Officer for the Cleveland Clinic Health System, the Principal Investigator for Cleveland Clinic's Biorepository, and the Vice Chair of Cleveland Clinic Institutional Review Board. She is active in multiple epilepsy societies and holds a master's degree in healthcare delivery science from Dartmouth College. So before we start our webinar for today, let me remind you the learning objectives for today. And then it is a pleasure to have you both. You can start. Thank you.
All right. Thank you, Yamile, for the very kind introduction. I'm going to start with some statistical data. So epilepsy affects 70 million people worldwide. 30% of these, a third of these, are actually resistant to medication. SUDEP, which is sudden unexpected death in epilepsy patients, accounts for about 17% of all the deaths in epilepsy. But it mostly affects the medically refractory population, and they tend to carry a lifelong risk of about 1% per year. In addition, they're also disabled because of the disease, and they have poor quality of life because of the recurrent seizures. In addition to all of this, 80% of the direct and indirect healthcare costs are accounted for by patients who actually have the drug-resistant epilepsy. So what are the goals of therapy for patients who are diagnosed with epilepsy? First and foremost, they have to be completely free of their seizures, if possible. They should have as minimum lifestyle limitations as possible. And in the United States, the biggest one is going to be the inability to drive that affects the patients. And then with the medications, you want as minimum or no side effects if possible. And if they have surgery, then you don't want them to have neurologic deficits after the surgery. So the first line is usually anti-seizure medications. And what can we expect from that? So this is a very popular graph that most of you must have seen already. It shows that up to 1980, we actually only had a handful of medications that we could use to treat epilepsy. But then after that was this very welcome upswing, and thankfully it's only going upwards, and there's been a couple more since this data was published. How effective, though, are these medications? So this was looked at in this very nice paper by Drs. Kwan and Brody, and what they found was about 47% of the patients will be free of seizures after just their first and one medication only. And then another 13% will get seizure freedom after a second drug. And then it adds another 4% with 3 or more medications. But that really comes to a total of 64%, meaning that 36% of the patients, which is this yellow region here, is still not seizure-free after trying multiple medications. We looked at the graph before. This paper was published in the year 2000, and even after 2000, there have been many new medications that have come into the market. So did that change anything? So the same group revisited the question, and they included several of the newer medications. But if you look at this graph down here, it kind of replicates what we just looked at, where after the first medication, even after trying newer medications, only 50% were seizure-free. With the second regimen, it added another couple of percent, even smaller number after a third regimen or a third medication. And then the trend kind of continues. So what we can say is that there are diminishing returns independent of the type or the number of medications that are tried. And that after a certain point, the patient becomes resistant to medications. So the ILAE task force tried to standardize and define what drug-resistant epilepsy was. And what they said was drug-resistant epilepsy can be defined as a failure of two adequately tolerated and appropriately chosen AED schedules to achieve sustained seizure freedom. So let's look at parts of this definition. Adequately tried, meaning that they should be tried for at a sufficient dose for a sufficient period of time. Appropriately chosen, which means there has to be some evidence base for the type of epilepsy that you're trying to treat with a certain drug. Two medications that can be either monotherapy or in combination. And then sustained seizure freedom, which they then defined as 3 times the longest pre-treatment seizure-free interval, or 12 months, whichever was longer. So what happens to this refractory population? What is the next step? The next step is usually epilepsy surgery. And what can we expect from this? So I'm going to go over, is epilepsy surgery effective? What happens to quality of life? What do we do with medications after surgery? And the mortality and the morbidity that goes along with surgery. So I'm going to start with, is epilepsy surgery effective? So the most robust data that we have out there is these 2 randomized controlled trials that were done in adult population, and then we have one in the pediatric population. The top graph here was a study that was done at University of Calgary in Canada. And Dr. Weeb's group looked at randomized 40 patients that had surgery, and then 40 patients that continued to have medical therapy. And what they found was 58% of the patients were seizure-free that were randomized to the surgical group, and only 8% were seizure-free if they were randomized to the medical group down here. So you can see that not only is this statistically a significant difference, but they also found that a number needed to treat of only 2 was required for any benefit. And then similar results were seen when the study was done in the US. The numbers in the study were lower, but the results are the same. That is, only 0% of the patients actually were seizure-free after continuing medical therapy, whereas 73% achieved seizure freedom when they underwent surgery. So I think it's fair to say that epilepsy surgery is effective, and based on these 2 trials, it's the gold standard for medically refractory patients. Now I'm going to talk about the outcomes and the predictors by the lobe of surgery. So let's start with temporal lobe. The overall seizure freedom with temporal lobe surgery is about 70 to 80% at 5 postoperative years, and it drops down a little bit to about 50% with 10 or more postoperative years. The predictors, the most important predictor that we have from the literature is actually an MRI lesion. The pathology is usually mesial temporal sclerosis. And if the MRI shows a unilateral lesion, then 85% of the patients were seizure-free as compared to only 63% if there was no lesion. But a negative MRI at the same time doesn't preclude you from surgery. And the next best test is a PET scan. So if a unilateral PET hypometabolic region was resected, the patients had good outcomes. The next important factor is really unilateral focal epileptiform discharges. And if more than 90% of the discharges come from one side, then the patient can have a good surgical outcome. And a factor of negative outcome was a history of generalization. So people that had a history of secondary generalization with their seizures tended to do worse than those who did not have that history. And we think that's probably because when they have a history of generalization, they have a more extensive and a well-recruited network and may not be as easy to resect. Coming to the frontal lobe overall seizure freedom is a little bit more variable than we saw for temporal lobe, and it varies somewhere between 20 to 70% at 10 years. This series at the Cleveland Clinic that was published by Dr. Jehi found a 44% seizure freedom at 5 years. And the factors which influence, again, are MRI. The most common lesions here are focal cortical dysplasias, as shown in this image, and 60% versus only 39% will be seizure-free if there is an MRI lesion. And the second most important factor for these patients is a completeness of resection, and that's irrespective of an MRI abnormality. So that is one of the main factors that drives this this wide range, because if there's a complete resection, patients are more likely to achieve a 70% seizure freedom. But because of being the frontal lobe and has eloquent cortex, a lot of times the completeness of the resection is limited by the eloquent cortex, and then you can have the poorer outcomes. And the pathology also drives the outcomes in frontal lobe, where we found that tumors actually did better than patients that had malformations of cortical development. And then finally, going to the posterior quadrant, which is the parietal and the occipital lobes, the overall seizure freedom was 25 to 90% at 2 to 5 years, and then 40% at 4 years, as shown in this paper again, which was a Cleveland Clinic series. And then completeness of resection, again, was an important factor. In this graph, you can see the blue line is the patients that had a complete resection, and they achieved about a 45 to 50% seizure freedom in the long term. But you can see this red line is an incomplete resection, which drops quite precipitously. And then the other factor, which was unique to the posterior quadrant, was ipsilateral postoperative spiking on the EEG. So if you had sharp wave spikes that continued on the EEG even after surgery, those patients tended to have worse outcomes. So going on to the next bullet point, which is quality of life, which I think matters more to the patient than anything else. What happens to quality of life after surgery? So this first paper here, again, a study that was done in Canada, looked at patients who had undergone surgery and then those that were continued on medical therapy. And what they found was that as compared to their preoperative baseline, there was a decrease in overall seizure worry and an increase in improvement of social function in those patients that had surgery as compared to those that had been continued on medical therapy. Another different angle of the same question was looked at by Dr. Spencer's group, where they actually looked at what the effect of memory and epilepsy surgery was and how that affected quality of life. So they looked at patients that had temporal lobe epilepsy at their baseline, and then 2 years after surgery and 5 years after surgery. And then they looked at and divided patients by very good seizure remission or good seizure outcome, where they had no seizures after surgery, intermediate outcome, which means they had a few seizures after surgery, and then poor outcome, where they actually had worsening of their seizures or continued to have the same amount of seizures after surgery. And what they essentially found that this first group here that did well, that was seizure free, improved in quality of life measures regardless of the memory. Whereas these other two groups depended on their memory outcome. So if they were to have a memory deficit and continue to have seizures, they obviously had the worst quality of life. So these were sort of what we call the double losers. Now coming to the next question, which is generally what the patient will always ask when you counsel them for surgery, is what happens to medications? Can we stop medications after surgery? So we actually looked at this data and we studied more than 600 patients that had undergone temporal lobe epilepsy surgery. And we looked at medications after surgery. So this blue line here is the patients that continue to be on their medications even after surgery. And those we found were the patients that did the best. They had least recurrence of their seizures. And then down here is the patients that stopped medications after surgery or had a decrease or reduced medications after surgery. And you can see that those patients did not do as well as the ones that remained, and they tended to have breakthrough seizures. Now, looking at the same data with a different outcome measure, which was angle 1, This is a more lenient outcome measure because it allows for some initial seizures, it allows for auras, and it allows for patients that eventually regain seizure freedom. The interesting thing that we found was this green line here, which was the patients that stopped medications after surgery, bumped right back up, and they started to go parallel with those that did not have any change in their medication. And what this could mean is that these patients that it takes, you have to stop all their medications all the way, and then they had a few breakthrough seizures. If you were to restart medications, they bump right back up and they achieve good long-term remission rates. But these patients down here in the red, who just by decreasing their medications had a return, were probably more dependent on their medications and were in general probably a more severe disease group, and they continue to do worse in the long run. And another thing that we found with this paper was that it did not matter whether medications were decreased early or late after surgery. Patients would break through a few decreased medications, but then a majority of them can actually continue to regain long-term seizure freedom. Looking at mortality, so we already talked about SUDEP, and SUDEP is the highest burden of SUDEP is really carried by these refractory patients. So what happens after surgery? Dr. Sperling's group looked at this data, and they looked at patients who underwent surgery and compared them to patients that did not have surgery. So patients that do not have surgery have about a 25.3 per 1,000 person year risk of SUDEP and death mortality. But this improves dramatically to 8.6 per 1,000 person years in those that underwent surgery. So surgically treated patients have lower mortality risk than the non-surgically treated patients. And amongst those, the patients that had the greatest benefit are those that went seizure-free. And then finally, even if you were to recur after having surgery, the risk of mortality is higher maybe than the patients that were seizure-free, but it still continues to be better than patients that were never operated on. So surgery definitely benefits this mortality rate. And then talking about morbidity, like any surgery, epilepsy surgery also comes with complications. So this paper stated that invasive monitoring with either stereo EEG or subdural grids had a 0.6% major complication rate, and resective surgery had a 1.5% major complication rate. Neurologic complications after surgery are slightly higher, they're 4.1%. And the majority of these are usually quadrant defects in visual fields. These were found to be higher in the extratemporal lobe surgeries. So now that we've talked about all these bullet points, what happens if you still were to fail surgery and had a recurrence of seizures? You can still have a second chance, and you can attempt to do resective surgery again in those patients that could fail surgery. And we looked at this data again at the Cleveland Clinic, this series. We looked at all the patients that had surgery, and we had 898, so close to 900 patients that underwent surgery. 500 of these were not seizure-free. And then we looked at the patients that were reoperated, trying to figure out why they had failed their initial surgery. And the reasons that we found, the possible reasons that we found was mislocalization, that we had missed the ictal onset zone, or incomplete resection, which could either be because we saw a residual lesion on the postoperative MRI, or because they were close to eloquent cortex and that limited their resection. And then there was a group where we couldn't find any possible cause for why they may have recurred. So when we studied this data more, we found that after a first surgery, they had over a 40% chance of being seizure-free. After 2 surgeries, however, it drops down a little bit, and then it drops down furthermore with 3 or more surgeries. So the overall outcome of seizure freedom decreases with every repeat surgery. which is very similar to what we started off with the medication data. So what that means is that patients need to be very carefully chosen for epilepsy surgery, and that we found the factors that affected this outcome were not the traditional outcomes that we talked about so far, but they were actually a history of having a generalized tonic-clonic seizure secondarily, or the sex of the patient, both of which are more inherent biological characteristics, either of the patient or of the epilepsy itself. So in conclusion, we think that there's a dire need for biomarkers that can help us understand the substrate of disease and the natural course of the disease so that we can better identify good candidates for epilepsy surgery. So with this, I'm going to actually hand over to Dr. Jehi.
Okay, thank you. Thank you, Ruta, and thank you, Yamile, for the kind invitation and introduction. So after Dr. Yardi went with us over the outcomes that we typically look at and consider with epilepsy surgery, I would like us to think about additional questions or issues beyond these traditional outcome measures that our patients care about. The one of them is the cost of surgery. I know this is a tricky question because the cost of surgery depends on the context. It depends on the country that the surgery is happening in and the healthcare coverage in that country. In the States, we did this study where we looked at what would be more cost effective for a patient with drug-resistant epilepsy to continue medications or to go through the workup that is required to undergo resective brain surgery. This study was necessary in our context because concerns about cost have been brought up by community neurologists or general practitioners as potentially being a hurdle that is keeping them from referring their patients with drug-resistant seizures for a surgical evaluation. The way we measure cost effectiveness is through this measure, which is called ICER, incremental cost effectiveness ratio. And it gives a dollar amount, a cost for each quality adjusted life year, meaning 1 year in perfect health would be one quality, 0 would be death. And different states of health are associated with different degrees of that quality. So after going through all of the modeling with the assumptions that go into rates of seizure freedom, cost of medications, cost of emergency room visits, etc., we ended up finding that resective surgery is the most cost-effective approach to manage patients with drug-resistant seizures, and that benefit is achieved as early as 1 or 2 years after the intervention. The other important thing that we found in that study was that just the act of referring a patient to undergo a surgical evaluation is still the most cost-effective approach in that situation. So what that means is you don't really need to be 100% sure that a patient is a candidate for surgery for you to be providing cost-effective care by doing epilepsy surgery. Even if this is a suspicion and you are starting the process of a referral, that is still the more cost-effective approach than continuing with medications alone. The rest of the talk we will spend on another issue, which is really what the question that our patients come to us with, which after talking about the cost, the medications, the morbidity, the mortality, the outcomes, etc. So we saw a lot of data that Dr. Yardi shared with us, and there's a lot more data that's out there. But really, when a patient is coming to us, they don't tell us, show me the data. What they say, what they ask is, should I have surgery, right? They're asking us if we think surgery is the right approach for them. And the way we decide how we answer that question now in 2020 is this. We just ask them to trust us because we are a doctor and we looked at all of their data. We read all the books. We know what's published. So we know if surgery is going to work with them or not. The issue with that is that this final step of making a decision as to whether to do surgery or not for a patient was done exactly the same way back in 1950. We haven't really evolved in our decision-making process when it comes to patient counseling with this ultimate step of decision-making. Should I have that surgery? In order for us to assess whether there was a problem there or not, there are many things that we do now the same way how we did them 60, 50 years ago, and it's still okay, right? So the first step there is, let's see if this is a problem, right? Maybe we are doing a good job of deciding what to do with those patients. So the way we answered this question is we took 20 cases, 20 patients with drug-resistant epilepsy who had surgery. And we presented them to 25 different experienced epilepsy specialists. The way we presented them is going through what routinely is done in the context of a patient management conference. So we reviewed all of the imaging, all of the EEG, basically all of the data that, as Dr. Yardi shared earlier, is the data that influences or correlates with outcomes. And then we asked them one question. If you had 100 cases just like this one, how many do you think will be seizure-free in 2 years after surgery? And as you see here, for that first case, the range of predictions of seizure freedom was anywhere from 30 to 80%. So what that means, if I am case one, and I walk in door number 1 and I see this physician, he will tell me I have a 30% chance of being helped with this surgery. I may then think twice about whether I want to do it or not. If I go in door number 2 and see this physician, he will tell me I have 80% chance of becoming seizure-free. That will make me much more optimistic about the surgery. This is too much of a variation if we really knew what we were talking about. How about the other 19 cases that we had? This was their spread. We didn't do much better with the other cases. In fact, what you see here in those graphs is the range of predictions for each case. The green color is cases who were actually seizure-free. The white are patients who recurred. And the conclusion of this whole exercise was that as physicians, we really have no correlations, robust correlation among each other, nor with the truth, with what ultimately happened. So we need help as far as our ability to synthesize all of this outcome predictor information and put it in a context that allows us to provide patient care. And that's when we started thinking at the Cleveland Clinic about using different tools, different methods to help with this patient selection process or with this outcome prediction process. And if you think about it, we are not alone in trying to innovate with tools that could help with medical decision making. In many other aspects of medicine, mostly in oncology, machine learning, for example, and artificial intelligence and the use of algorithms has gone a long way in helping with objectively distilling large data sets. So the question is, can this type of innovation help us in epilepsy? This is the first paper that we published looking at that, and it was a paper from 5 years ago now, where we took about 800 cases, 800 patients from the Cleveland Clinic, developed a statistical model, which is called the nomogram. I'll tell you what's the nomogram next. We developed the model, and then we validated it in about 600 patients who were international, from France, Italy, Brazil, and some from the States. And we found that it does equally well in both cohorts. What's the model? A nomogram is a statistical model that integrates multiple different predictors, multiple different patient characteristics, and boils them down into a prediction that only works for that one patient. Remember, the question is, should I have surgery? So as a doctor now, I don't have to guess how your whole clinical situation fits. And I can give the appropriate weight to the different characteristics that you have. The issue here at its core is that patients don't come in clean buckets. I don't know about you, but when my patients walk in the room in clinic, they don't come and show up as a young person who has one lesion that is very visible on the MRI, who only had epilepsy for a short time, only has one type of seizure, never had a convulsion in their life, and their EEG is just perfect. Sometimes they do, but that's a minority of patients. Most patients have some factors that check good, some that check bad, and we are left in the middle trying to consolidate all of this and figure out what to do. What happens with the nomogram is you just plug in each individual characteristic. It gets a point score. You add up the scores and then go down here through the line that has the 2-year and the 5-year chances of seizure freedom. This is if you are going to do it manually. I wasn't expecting anybody to do it manually, but over the years, I've learned that some people printed this and are drawing the lines up and down. It is much easier to do it online. And this is the website that you could go to if you're interested in this option. And you input these simple clinical. So how old was the patient when they started seizing, age at the time of surgery, gender, seizure frequency, cause of seizures, and if they had convulsions or not. We looked at many more variables, but these were the ones that ultimately mattered for the model. And then you click that submit button, and then you get for that one patient, what are their odds of being completely seizure free or of having an Engel score of 1. This model was not perfect, but it did better than the physicians. Remember, as physicians, we had no correlation with the actual outcome. This one had a concordance index of 0.6. To put that in context, if a model is perfect, meaning it's always accurate with whatever it's predicting, its C statistic would be 1. If it's always wrong, it's 0. If it is like the flip of a coin, it's 0.5. Physicians, we were 0.4. This model is 0.6. So it did better than chance, better than physicians, but we would obviously want it to be much more accurate so that we could trust it in clinical care. So what did we do then is we incorporated additional measures. Remember, this one was just built using very simple clinical characteristics, age, gender, etc. But recall all of these advances that we use in our pre-surgical evaluation, the EEG, the imaging, the different kinds of imaging, etc. Then there's a lot more that we could learn from in order to improve this algorithm. And the question is, could we then improve it if we add these additional characteristics? And the answer to that is yes. This is a paper that's now under review where just by adding volumetric data from the MRI, we bumped up that C statistic to 0.75. So now you're talking, it's 75% accurate. The other issue is that we are interested in outcomes beyond just seizure freedom. Like Dr. Yardi mentioned, memory comes up, naming comes up, cognitive function comes up. People want to get their seizures treated, but they need to know what price, cognitive price, quality of life price would they have to pay for it. So we also our teams built nomograms that could help with predicting naming decline after temporal lobe surgery. So this way, you are again individualizing the prediction of that cognitive price of surgery. And sometimes there is a trade-off between seizure freedom and other outcomes. I don't want to just know what the naming risk is with a surgery, and I don't want to just know the seizure freedom rate with surgery. I want to know both. And the perfect example for that is a situation that we're often faced with, which is in the context of a normal brain MRI, a normal looking hippocampus in a patient that we are suspecting to have a dominant temporal lobe epilepsy. The issue here is we remove the hippocampus, we worry about the cognitive price of doing that if the hippocampus is normal on imaging. We leave it in, we worry about the risk of seizures recurring and the surgery being ineffective. So how do we weigh both? How do we counsel a patient about what the risk and what the benefit of a surgery in that context would be? That requires us being able to look at both the naming outcome and the seizure outcome with the same view at the same time, and knowing what we will get either way, whether we spare or we remove the hippocampus. And this is one of the papers that we just published where we looked at the question in that regard. So the bottom line here is the following. With all of the data that Dr. Yardi shared, it is clear that epilepsy surgery is the most effective treatment when you have a patient with drug-resistant seizures. Nothing else comes close to it. If you want to save that patient's life, they need to have epilepsy surgery. They need to have a resection. Palliative options are good for palliation, but they are not a cure. And unless you aim for the cure, that patient is still at risk for sudden death and is still at risk for memory decline and global atrophy and all of the complications that happen from uncontrolled seizures. Surgery is the most effective option. It is also the most cost-effective option to provide that care. And despite all of the knowledge that we have with isolated predictors of outcome, we've shared many of those with you today. I hope we communicated also that we need to innovate in our processes of expediting and improving patient selection through a better understanding of how we can do outcome prediction for patients who are considering surgery. And with that, I will stop, and Dr. Yardi and I are open for your questions.
So thank you both for an amazing talk. So one of the questions that we have is this nomogram that you presented valid for all types of focal epilepsies? And did you find any difference among lobes? If you have a patient with temporal lobe epilepsy, the outcome will be different from a patient with frontal lobe epilepsy?
Yes, obviously it is different, and that factors in the nomogram because one of the variables that people need to input in it is the lobe of surgery that they expect the patient to have. There is a lot of calculations that go on the back end with what we call interaction terms. So as we developed it, we took into account things like how specific variables influence outcomes differently in different patient cohorts. One example is generalized tonic-clonic seizures. A history of convulsions is a very poor outcome predictor after temporal lobe surgery. If you think about it, seizures that are truly in the hippocampus usually stay in the hippocampus for a long time and don't generalize. So people with temporal lobe seizures who generalize quite often do a lot worse with a temporal lobe resection than, say, frontal lobe epilepsy patients who have history of convulsions. We have to account for that, and we do, because in the programming of the nomogram, we took all of the known variables that influence outcomes and accounted for them through these interaction terms with the lobe of surgery. It's just that from the end user view, they don't need to know about all of that math. What they need to input in is, does the patient have convulsions, yes or no? And then what lobe of surgery is it, do you expect to operate on? And all of the calculation happens on the back end.
Okay, so another question is, how about the results with repeat surgery, with reoperations? Is there a change between one reoperation to two reoperation to more reoperation?
That's a Dr. Yardi question. She wrote
I can take that one. So the graph that I showed basically was show the first surgery, has a better outcome. The chance of outcome of the first surgery is better. And then when you go to the next surgery, it falls down a little bit, which means fewer patients are likely to benefit than the first time. And then as you go to 3 surgeries or more than 3 surgeries, it again falls a little bit lower. So every time you approach a reoperation, there is a percentage of patients that will benefit from the surgery, that will be seizure-free from the surgery. But if you compared how many patients became seizure-free after the first, compared with the second and compared with the third, that number, that additional benefit goes on decreasing.
Thank you. So another question is, I know that you right now are collecting data regarding genetic changes, like somatic genetic changes in these epileptic tissues from people who were taken to surgery. Have you found a tendency or some kind of change between people who has the somatic genetic mutation or people who don't have?
We are looking at that, and I still don't have anything to share about it, but we're definitely looking.
So right now we don't have more questions. Apparently it was a very clear talk. It was an amazing webinar. Thank you very much for contributing to it. This was amazing.
Thank you. Thank you, Yamile.
So this is it. So we are approaching to the end of this webinar. Thank you for joining us. And remember, we will come back on January with Dr. Eileen McGonigal. She will talk a little bit about extratemporal surgical epilepsies. And that's it. Thank you very much.